again might work. You can use the chat box for questions or comments throughout, and I'll help to moderate those at the end. We may use some anonymised information from the webinar, so just so you're aware of that, and this session is being recorded. So we have two presenters tonight. We have Lisa Farrelly, the Business Manager at the Health Identifier Service HSE, and Loretto Grogan, who's the National Chief Nursing and Midwifery Informations Officer at the HSE. We also have with us Elmarie, Cottrell and Brid Ryan. So Brid is the clinical lead of ePharmacy HSE and Elmarie is the HIMSS operational lead. And they are here with us this evening to answer questions at the end. But I'm going to hand you over now to them to introduce the presentation as a whole and to give you a breakdown of what will be covered this evening.
Thanks, Michelle. Good evening, everyone. Thank you for taking the time on this lovely sunny evening to join this webinar. My name is Elmarie and I'm a Chief 2 Pharmacist for the HSE, currently working in the area of health informatics as the HIMSS operational lead, which is an e-health and e-pharmacy project within the HSE. So healthcare or clinical informatics is the use of information technology within our healthcare system to provide clinical care, and it's one of the fastest growing areas in health currently. This is the second webinar of a two-part series, which is focused on the area of health informatics, with the objective of making people more aware of the current digital health projects, as well as providing people with an understanding of some of the basic terminology and concepts that are used in this area. So as Michelle mentioned, Lisa is the Business Manager with the Health Identifier Service within the HSE, and she's going to speak to us tonight on the role of the individual health identifier in patient identification, which is a topic that is really important with the advancement of digital technologies. And Loretto is the National Chief Nursing Information Officer and will provide an overview of the importance of standardisation when implementing national digital systems. So I'm going to hand over to Lisa now, and Lisa will present first. Thank you.
Thanks very much, Elmarie. I'll just get set up here now. Okay. Is that okay, Grace?
Yep, working perfect.
Perfect. Thank you so much. Good afternoon, everybody, or good evening, I should say, and thank you very much for this opportunity to speak with all of you. Always delighted to get an opportunity to speak on the IHI and to spread the word on how we are open for business and very much delivering this identity management solution. So the key points that I'm going to take you through tonight is that the IHI is up and running and operational. What are its key features and benefits, how we're integrating the IHI with national systems, and how success hinges on frontline data quality efforts. So straight into it then, the backbone of the Health Identifier Service, we call ourselves HIDS for short, is the Health Identifiers Act, which was enacted in 2014. And this governs two separate national databases, the first being the National Register of IHIs, which I'm going to talk to you about tonight, and the National Register of Health Service Provider Identifiers, which hopefully I could come back at some stage in the future and maybe talk to you about that at a later stage. So essentially, the HIDS team operate the enactment of the HIDS Act on behalf of the Minister for Health. We're very fortunate within HIDS to have our technical partnership and our technical providers in-house within the HSE, so we're not dependent on an external provider. So it's very much a partnership between HIDS Business and HIDS Technical within the HSE. So why is the IHI so important within Irish healthcare? So it's key in terms of reducing the risk of medical errors associated with incorrect patient records or treatment, and essentially providing patient safety. It can deliver efficient healthcare operations by reducing admin burdens, minimises duplication efforts and optimises resources. And in time, the IHI will enable health records to be seamlessly accessible across the continuum. And I'll give you an example of that in a few slides. And as Elmarie mentioned, it is absolutely pivotal and foundational to the digital journey that we're going on now across a range of healthcare services. And some of these include the health app, the summary care record, and the shared care record. The IHI is essential to the delivery of these solutions. So some key points. All of us here on this call already have an IHI. Everyone in Ireland has an IHI assigned already. Your IHI is assigned for life. It'll never be used for somebody else, so it's unique to all of us. And it can be used to safely identify and link you across multiple health systems and services. So what does it look like? So at its core, it's a 10-digit number. In its full format with GS1 international standardization, it's an 18-digit number. But in time, the number we will all become familiar with is 10 digits in construct. It contains only demographic information. It'll never contain medical or clinical information relating to you. So one of the key questions I'm often asked is, do we know our IHI numbers? So not at this point in time. Citizens are not yet familiar with their IHI, but this is going to start to change fairly rapidly. I suppose the first experience of the IHI for citizens will start to be the health app and other digital solutions as they come on stream. I'll talk to you in a little while about PharmaVax, where a lot of you, I'm sure, are familiar with seeing the IHI and what that looks like. But for the moment, citizens are not aware of our IHI. So our current priority is to dynamically integrate the IHI into a broad range of national systems to rise that tide of IHI. And I'll talk to you about that in a few slides. So this is Brid Murphy. Brid comes to a lot of conferences with me, and it's kind of my way of explaining what it is. So we see Bridget here on the left. Bridget was born in the Rotunda Hospital, and she would have been assigned an MRN or a medical record number at time of birth. She then went on maybe to have some childhood vaccinations through her GP. And as she's a child, she'd be entitled to a GP visit card, and she'd be assigned another number under the GP visit card scheme. She may well be assigned an NIO number or through the National Immunisation Office and be given a unique ID for her vaccination programme through the primary schools. Bridget has in time maybe shortened her name to Brid, and she in turn goes on to have a baby in Holles Street where she has a new medical number. She maybe attends a cervical screening programme through her GP, and she's provided with a national screening service ID through that service. In time, she has a hip replacement in Galway University Hospital and is assigned a medical record number there. Over the course of her life, she may be brought in for various vaccinations, including the COVID vaccination, and would be given a unique Salesforce or a COVAX ID through that programme. And in later years then, she may become a resident of a nursing home and apply through the Fair Deal scheme and be given various IDs through that process. So I suppose the visual here is intended to demonstrate that throughout our lifetimes, we all attract a broad range of unique IDs, but those IDs only have currency within that particular service. So what the IHI is intended is to be an overarching number that provides continuity of identity across all of these different platforms. So what we're trying to do is embed the IHI into a range of national systems that in time, that transfer or that accessing of a broad range of services, that the IHI will be unique across all of these. It's also worth calling out there that the IHI can handle derivatives of spelling such as Bridget Murphy or Bridget with a DG or a Brid or Biddy maybe in later life. So we have a lot of our work in the background has gone into normalization and algorithms that can handle these type of derivatives of names as well, which is always helpful. So as I said earlier, your IHI will never contain any medical or clinical information. So what does it contain? So it contains a broad range of demographic data, particular to each of us. But what we use is 9 searchable data items in order to attract and match you to your correct IHI. So when a consumer system sends data into the IHI index, for instance, COVAX or PharmaVax or a PAS system within the hospital, what we're doing in the IHI index is looking at 9 demographic data items in order to try and match those to the correct IHI. So we talk in terms of what we call the core 4+1. So the core 4 that must be on any demographic record in order to kick off the search must be surname, forename, sex, and date of birth. So we must have these on the record before we can effect a search. And then we must have what we call a +1. So we must have the mother's birth surname, address line 1, the air code, mobile phone, or PPSN. So we must have what we call core 4+1 in order to do an IHI search. So the more of these +1s that we have on the inbound records, the greater the chances of safely matching to the IHI on the back end. So the key data that we hold are the following list. I won't read them out individually. We also hold PCRS scheme numbers, medical record numbers, and PPSN on the back end. So these are all called out in the Health Identifiers Act, and the HSE is legislated through that piece of legislation to hold and store these records. The legislation also allows us to pass these records back to a consumer system where the IHI match is made. The legislation allows us then to augment the consumer system with any of these data points. And that's something that we are working on in time. The first offering really being the date of death, knowing date of death, particularly in hospital settings. It's terrifically valuable in terms of identifying people who are on waiting list and obviously not causing distress and contacting individuals or their families who have indeed passed away. So when we're dealing with any consumer system, we talk a lot about the IHI match rate. So that's the percentage that we're able to achieve based on the inbound consumer data from that consumer system and what percentage of IHIs we can match by return. The IHI, our heads, we're involved in I suppose predominantly the business side of the IHI was stood up in January 2020. And then when COVID struck in March of that year, the IHI was used to great effect throughout the whole COVID programme, from the early days of track and trace right through to vaccination and into vaccination certification as well. So we went from a broad range of pilot projects, quite local, small pilot projects, to having the opportunity to test the IHI on a broad scale. So it really is only since 2022 that we've now started an accelerated programme of embedding the IHI into a broad range of national systems to rise that tide of IHIs. The main focus for the past year really has been stitching the IHI into the patient administration systems across the hospital infrastructure. So that's broadly complete now at this stage. We've also completed IHI integration into GPs, into the GP practice management systems. Again, also complete PCRS into the various schemes, medical card, GP visit card, that's complete as well. So what we're really trying to do is to rise the tide of IHI integration into those big national systems. The main thinking is that once we get IHI embedded in the hospitals, all those systems that then hang off hospital administration systems can in turn then benefit from the IHI. So it's very much a sort of a front door model. If we can get the IHI into hospital systems through the front door, then systems can hang off that. And our engagement is then with the PAS systems. And as we update PAS systems with the IHI, or as we revalidate, those downstream systems benefit in turn. So a big program of work underway at the moment. There's approximately 70 downstream systems of hospital PAS systems. So and they all have different degrees of technical capability and different structures. So a good deal of work going on in that space. So the list up here represents all the different systems that we are engaging with that are at various stages of IHI, either discussion or integration. So a significant body of work in place across all of these different services and schemes. To give you an idea just of some of the IHI match rates that are being achieved at the moment, GP systems, they're averaging about 91% IHI match rate. PCRS, typically very strong, high 97s typically. Hospital systems, more or less around 77%. COVAX 81 and PharmaVax, actually that figure needs to be updated. I had a look at it just before coming on stream and it's 97.7 for the last 10 days. So very strong on the PharmaVax side. So as I said earlier, the quality and quantity of data coming through really does affect the IHI match rate. Typically systems that have the PPSN on the patient record tend to perform very well in IHI matching as well, given that unique binary nature of a PPSN. So typically GP systems and PCRS and PharmaVax would have that PPSN, which enable those high IHI match rates. Hospitals tend not to collect PPSN, so then they're much more reliant on mobile phone or address line 1 to create those IHI matches. But we're working very actively on a program of work to increase IHI match rates across the board. The numbers here, just to give you a flavour of the kind of the traffic on the back end for the IHI index. So you can see there's quite substantial volumes of requests coming through to the infrastructure. And these are dynamically calling the IHI every day. So if you attend a GP or you attend for a vaccination, those patient records are dynamically interfacing with the IHI on the back end to confirm that, yes, it's the correct Lisa Farrelly and her IHI has been returned. And typically then if any data changes on that patient record, in order to keep everything accurate and up to date, that data comes in again for revalidation. And so all of that happening in the back end, supported by our technical partners. So I just wanted to touch on kind of PharmaVax, given the audience here, and something that a lot of you may be familiar with. So the IHI is it's a real-time interoperable structure with the PharmaVax system, and it is a direct interface into the IHI. Excuse me. And when we talk about a direct interface, it is that it's a real-time lookup. So when Lisa Farrelly attends the pharmacy for a vaccination and her record is opened or her record is updated, it's calling the IHI index in the back end to confirm that if a new mobile phone or a new email address or a new first line address has been entered for me, that IHI remains the same and that it's accurate. So as I said earlier, it's the 10-digit IHI number that's being displayed on the patient screen. First name, last name, DOB, gender and PPSN are the main data items that are being used on PharmaVax to search for the IHI and that are used in the ads and update screen. So then on matching with an IHI, a call is then made to the vaccinations API in the HSC data lake, which retrieves the client's vaccination history. So this is why it's really important that the data quality is good on the front end, because once it calls the IHI, it then goes on to retrieve the vaccination record from the data lake and return that onto the PharmaVax system. So the IHI API call is made on the correct vaccination record screen, on save or change of identity is restricted. So it's just really dependent on that high data quality being imputed at point of client interaction. Verifying a client's identity is a prerequisite to entering a vaccination on PharmaVax. So that's the piece where you may be asked to see some form of identification, that you have that certainty around dates of births and names. Accurate client data recording is vital. Again, this has been seen time and time again. It's about getting it right at the front door because of those impacts downstream. The key downstream systems to PharmaVax would be the COVAX data quality team, HSC Live, which is our comms portal with the public who make queries, the data lake, data quality department, and critically then the retrieval of the correct client vaccination history for PharmaVax. So critically dependent on having the correct data imputed. In terms of some of the reasons for no IHI match in PharmaVax, so this is an analysis based on order of frequency. So the number one reason for not returning an IHI is the wrong DOB or date of birth being keyed in. The client's DOB must be in the format MMDDYYY, as we're all familiar with, but sometimes data can be miskeyed or maybe months and days flipped, and this will then result in no IHI being returned. Wrong gender is number 2 then for not returning an IHI. Number 3 then, wrong first name, wrong spelling or an abbreviation. And again, we say this on all presentations, that it really needs to be the official birth cert name or the legal given name, or what name do you have on your passport, or what name is on your birth cert. So while we can do some normalization around the Bridge piece, having that official birth cert name is really the way to go at point of keying in. Wrong last name And again, spellings or different last names. We see some of this on the data analysis piece as well. Something that happens more frequently than you'd imagine is the wrong PPSN, different client PPSNs, typically husband and wives maybe mixing up their PPSNs, or father, sons, or mother, daughters. So again, just being really confident that it's the correct PPSN for the individual. But in saying all of that, the IHI match rate on the PharmaVac system is very, very strong at about a 98% IHI match rate. So clearly data quality is very good at the front end. So these are just some of the things to watch. Again, some kind of similar points then on the COVAX system. It's also a real-time interface to the IHI. Again, the 10-digit number is displayed. And the IHI is the primary source of identity within the COVAX system, similar to PharmaVax. And it's used to link booster shots to patient records and drive that connectivity. And that data is passed down to the data lake for further analysis in other systems. Another key piece that we provide to COVAX is we do a lookup for the COVAX system on dates of death, to pass back information if someone has passed away. So that we can stop or at least prevent SMS messages going out, inviting people to come in for vaccinations and causing distress to families. Now, we don't always, we're dependent on the Department of Social Protection telling us about that date of death on a direct interface we have with the Department of Social Protection. So if we get that date of death information, we can then plug it into COVAX as well and prevent those SMSs going out. So the real driver here, now that we have connected the IHI into a lot of these national systems, is we need to keep IHI match rates up around kind of 98% for this to have wide-scale interoperability, and, as I say, being able to do that comprehensive downstream system usage within hospital systems and so on. So the job of work is now switching from IHI engagement and interoperability to match rate improvement, if we are really to see the IHI live and being used across the board. So this really does hinge on data quality and getting it right first time. So what we've done is we started a program of work, primarily working with hospitals, to really try and drive data standardization across the 9 fields that do affect that IHI match rate. And we've created this leaflet, and I'm happy to share it with this group afterwards. And it's just calling out, based on our own analysis, that the types of errors that we see that prevent systems and sites from getting IHIs returned. A lot of it is fairly obvious stuff around special characters and, misusing mobile phone fields to say things like, dad's number or call after 6 p.m. It's those types of things. But we need to start working on a comprehensive rolling program of education and training to make sure that all of these are understood at the point of registration, because they have significant downstream impacts on all sorts of services if they're not got right first time. I won't go into this in too much detail. I suppose it's just to call out that there's a range of initiatives to improve IHI match rates. Data standardization is one of them, staff education and training. The IHI is a really powerful tool for data cleansing algorithms to identify and assist with duplicates. And as we're currently working with the Sale to Hospital group in a comprehensive deduplication process over there as that hospital group merges with Letterkenny. So it really is those use cases of using the IHI to good effect. On our own side too, we have a back-end data quality office that are constantly repairing IHIs on the back end. And we're working on systems now where IHI matches are made, that we can start to pass back high quality data, the first offering being the date of death, but in time we hope to roll that out to being the PPSN, air code, other high value data items that we can push out to consumer systems along with the IHI. So it is really like seeing the IHI as a key, that if you create that safe match to the IHI, you're then opening the door to having other high quality data items returned onto that consumer system. We're also working to bring in new high value trusted sources onto our IHI index. For example, we're in advanced discussions with the Department of Transport because we recognise that all of us that tax the car every year or change the car, that we're more likely to tell the Department of Transport what our new address is rather than maybe the Department of Social Protection. So we're really trying to engage with other government departments that have access to high quality data items. So that's part of our work as well. Similarly, HIDS, we're really trying to advance thinking in terms of algorithm and logic and starting to use AI and digital solutions in this arena as well, in terms of machine learning and advanced solutions to improve our matching opportunities as well. So some work has started in that space as well. So no magic bullet, I suppose, is the takeaway there for IHI match rate improvement. It's a range of solutions, both front of house and internally to the HSE as well. That's it, guys. So just a whistle-stop tour through the IHIs, and I've put our generic address up there, ihi@hse.ie. If anyone has further things that they'd like to follow up down the line or to chase down with us, we're more than happy to accommodate that. So thank you all very much for your time.
Thanks a million, Lisa. We might move on to Loretto next and take any questions then as a group at the end, if that's okay with you, Loretto.
Yeah.
Yep, that's perfect. And Brid, can I just check if you can see my slides and hear me okay?
Yeah.
Yeah, I can see and hear you.
That's great. Good evening, everybody. My name is Loretto Grogan. I'm the Chief Nursing and Midwifery Information Officer, and I'm delighted to be here to talk about the importance of standardisation. And Lisa, I'm just thinking you should probably look at a Ryanair pricing model for misspelt names. That might that's been a successful model for them. So who am I? I am, like I said, working in the HSE, and I have strategic responsibility for digital health for nursing and midwifery across acute and community services or integrated services in the HSE. And I work really closely with colleagues like Brid, Lisa and others. Just one thing about digital health, it's a team sport, and the whole data standardisation is a team effort. So tonight, I just have 44 slides. Apologies about that, Brid, but I really just want to give everyone a flavour of the importance of this area and why we all really need to collectively look at standardising our data. And like I said, it's a team sport, and it'll be a joint effort by everyone in the HSE. And pharmacists have a huge role to play in this arena. So I'm going to talk about why we need to standardise our data. I'm going to focus on patients, clients and citizens, and I'm going to talk a little bit about what's happening now and why it's so important that we have a real focus in this area and what's happening next in the health service around this. It's just a very quick introduction. Digital health is the use of information and communication technologies in health products. And just digital health really does involve change in healthcare systems and new skills to improve health efficiency and productivity. And there are a number of terms that are used interchangeably, like informatics and e-health, but that term digital health really does bring in around that organizational change piece and the new skills that are required. And ultimately, it's about the right data, about the right patient in the right place and at the right time to ensure safe and efficient provision of care services. So again, people, process and technology, and in the middle of all those is data. And we are moving from thinking about digital transformation to it's more about healthcare transformation enabled by digital technology, and moving the emphasis towards data and data flow rather than the tools, because we know data is at the core. So why standardize our data? So the first thing I want to talk about is the patient and the patient's journey. And we know the patient's journey through healthcare can be complex. Patients go through a number of services. Patients just rarely have one thing wrong with them. They rarely are just in one place, and they're rarely just seeing one healthcare professional. And every patient, person, citizen goes through a journey. And again, this is a patient's oncology journey, and right through from symptoms identified, diagnosis, treatment choices, therapy cycles, and survivorship or disease progression. And you'll see the variety of healthcare professionals along that patient's journey. And that on every aspect of that patient's journey, there's information, there's data and information. Someone's entering the data, someone's looking for the data, someone's making clinical decisions from the data, someone's entering data, and the patients are now using their own data as well. So our whole healthcare service is built on information. I think sometimes that's a piece that we actually forget, that information is core for healthcare delivery. And our patients are also telling us that they want their own data and they want us to have good standardized data in the system. And that's just some results from the IPOSI Citizens Jury that was held in 2021. And the patients have told us that they want a connected quality digital health information system. They want to be the owners of their own information. And they want us to have collective responsibility to do the right thing. And I guess that's what myself and Brid and Lisa and others are working on, is that collective responsibility to really do the right thing now for the health service in terms of digital health. And again, another significant feedback was we need to treat data as a national resource, which it really is. So I'm just going to touch on why it's so important now to have a collective responsibility for this. I'm going to just touch on the areas of policy and strategy. So currently at the moment, the Department of Health have been working on a Digital for Care, a digital health framework for Ireland 2024 to 2023. And we have been working in parallel with the department on the development of a digital health strategic implementation roadmap. So this is a new direction of travel for digital health for the country. Our first digital health strategy that was ever produced in the country was in 2013, but that's quite dated now. So currently at the moment, that Digital for Care, the new framework, is with the Minister for Health, and we're hoping that it's going to go to government over the next number of weeks, and that'll be published. And again, there's a digital health strategic implementation roadmap. So those roadmap and the framework, there's 6 strategic guiding principles across both documents. So those 6 principles are patient as an empowered partner, digitally enabled workforce and workplace, digitally enabled and connected care, data-driven service and capacity management, digital health ecosystem and innovation, and digitally secure foundations and digital enablers. So again, there are those 6 principles, and 48 key initiatives have been identified to be progressed over the coming years. And again, those 40, I'm not going to go through those 48 key initiatives, but there's some really important key initiatives in there, and data is going to be at the core, and standardizing our data is going to be at the core of the successful implementation of those key initiatives. So another significant area that we need to consider is the European health data space. So what's changing for health information in terms of the European health data space? So this is the path to a digital decade 2030, so the transformation of society and the economy across the EU. So the European health data space is the first EU sectorial data space and regulation with a direct effect. So this is something that we are absolutely going to have to adhere to in Ireland. Again, that just from a policy perspective in Ireland, then we've got the Health Information Bill. That general scheme was approved in April 2023. As I've referenced, we have our National Digital Strategy and we have the framework. But the health information policy and the integrated health information system that supports the delivery of integrated care and ensures efficient, secure sharing of health information for care and treatment and for relevant purposes. So these are all the key areas that they've identified. And Lisa's just touched on identity management. But again, it's ensuring a standards-based approach. It's improving access, sharing and use of health information. It's building trust. It's identity management. It's strengthening our health data collections and our infrastructure. And it's really about empowering patients and service providers with better data. Again, I'm not going to go into this in too much detail because the slides will be shared afterwards. But My Health at EU, each person will have access to their personal health records for medical treatment in Ireland. So by 2030, every patient or every citizen in Ireland has to have access to their own personal health records. So this is quite a significant driver for us to start standardising our data, our health data. So again, the main pieces that will be looked at in that is patient summaries, electronic prescriptions, electronic dispensations, medical images and relating image reports, lab results and related reports, and hospital discharge reports. And again, who will have access to and the ability to input? Healthcare professionals, natural persons, and a representative of that natural person. I'm not going to go into too much detail, but this, again, these are the key areas that we're looking at. And we have, like I said, a significant effort within the HSE to work towards standardizing this data and having our data in a really good, robust place. Again, data sets, we'll share the slides, but data contained in EHRs, which we don't have a lot of, I'm going to go into that later, biobanks and databases, healthcare related administrative data such as insurance status, reimbursements, genetic and genomic data, other human molecular data, registry data, clinical trial data, that's after completion. So another significant program at the moment is My Health at IE program. And that will deliver three important things. One of them being the National Shared Care Record. We're currently out for tender for that at the moment. And that's a new system to bring together health information from lots of different IT systems, such as general practice, hospitals, community services, primary care reimbursement services, pharmacies. The HSE app, which is the HSE patient app, which is giving patients access to their health information and making it easier to manage their healthcare through a secure mobile app. And again, that's putting a significant onus on us to get our data right, because our patients are now going to be looking at the data that we enter. And then there's also like the My Health.IU, and that's making the Shared Care Record and HSE app work with other health service systems across Europe. So again, the HSE, the patient app, will contain things like your health credentials, so health identity, again, really, really important. Medical card, your European health card. It'll contain your appointments, prescriptions, test results, scans, and your personalized health service, with the aim of kind of signposting you towards various education material, personalized communication, and like, again, self-care advice and information. So currently, where we're at with that, that's in live production at the moment, and it is scheduled for public release, the first phase of Q4 2024. And there are some of the key areas that will be included in the app for that first release. So health cards, credentials, appointments coming from our patient administration system, medications. So that'll be reimbursed medication from PCRS and self-declared medication at the start. Enhanced care pathway services and signposting, and HSE Live support. And again, this is a program of work that's going to grow and evolve. But like I said, that's scheduled for phase 1. Again, huge onus and responsibility on us to standardize our data and get it right. So other big programs of work that are running at the moment that require, like I said, really robust functionality is the implementation of telehealth. The HSE published a telehealth roadmap, again, from 2024 to 2027, outlining some of the key actions and programs of work that we're progressing in the telehealth space. So at the moment, some of the bigger programs of work, we're establishing 2 acute virtual wards in St. Vincent's and the University Hospital in Limerick, with a plan to scale those nationally next year. Again, those wards, we're currently procuring a system, and we will be looking at the data that's running through that system and the other data sources on both of those sites. And again, really important to look at that robust standardized data. We also have telehealth, a number of telehealth seedling projects running in the areas of oncology, hematology, respiratory, cardiology, and renal patients. And again, we have cohorts of patients, and we're preventing admission to hospital. And we are looking at doing a piece around standardizing those key data sets that are within those smaller applications. And again, just to highlight, standardizing the data in the smaller applications is as important as standardizing the data in the bigger applications. And like Lisa referenced, having identity built into absolutely everything, anything that's an application or a system needs to have identity built in, because all that data needs to follow the patient. And again, there's just the acute virtual wards, and that just shows the various degree of clinical interventions within care at home. This is an area that's hugely expanding in the country. And again, for most of these, we'll be running data through the applications or systems that we're using. And this just highlights the data journey and that end-to-end patient journey. This was a gestational diabetes service that was established in Holles Street. And you can see the amount of systems and professionals involved. And like I said, you can see the data journey from the various, like IPMS, the patient administration system, emails, the waiting area. So they would be the lab system, the EHR, and then there's the applications that are running in the patient's home. So again, just having that standardized data, understanding where the data is, who's entering it, and having the same data. So there's there's a piece around clinicians understanding that data. So there's a number of clinicians involved in the patient's journey. And again, that standardization is core. So where are we now? Just to say, healthcare data is difficult. And I know Brid and colleagues everyone sees this and goes, it really is when you start to go down to that granular level of looking at your data. So currently our data is located in a number of different places. So it's in filing cabinets, it's in clouds, it's on desktop servers, it's on other vendor servers. Our data is structured differently. So we've got some structured data. We have like SNOMED, ICD-10 AM, so we've got different coding mechanisms. And then we've got a lot of non-structured data, like free text. So our data is in many different formats. It's in, like, could be in images, PDF, Word, Excel spreadsheets. Our data is defined differently. And so like I said, you could have a broken hip, but that could be called a fractured hip in another place. Data complexity. Again, that's a key consideration. So humans are entering data into a computer, and that is prone to error. And regulations and requirements. So just keeping up with regulations and requirements can be quite complex, like GDPR, and we've got more regulations and requirements coming down the line. So currently at the moment, we have data in a number of different systems. We have, like I said, St. James's Youth Cerner, and we have maternal and newborn in our maternity hospitals. Again, that's a Cerner, but there are different instances. Tally University Hospital have Canis, the National Rehabilitation and National Forensics using InterSystems. Our general practice uses Clonwilliam. Older person services uses Clonwilliam also in care notes. And none of those systems currently talk to each other. And within those systems, some of the data might look the same, but some of that data might look very different. So we have 2,000 standalone ICT systems at the moment. Again, we have minimum standardization. And we have, and now Lisa referenced for her program of work, they have really looked at that kind of quality assurance. But outside of that, again, there would be, we have a way to travel in terms of data quality assurance. And we have really minimal or no governance of data sets. And they're all the big areas that we're starting to look at the moment. Just in terms of health data, we have huge volume of health data in our system, from administrative, clinical, lab data, medication, audit, metrics, research data, and every day we collect vast amounts of it. All of that data currently is in silos. We duplicate what we do. So we know if you move from Beaumont to Cork, you probably have the same set of labs and RADs done. It's poor value, and again, we have poor access to data, and for any of our colleagues who are working in the hubs and out in ECC programs, huge challenges accessing data at the moment. So again, just it's complex. So it really is about reducing that complexity and simplifying, and standardizing our data will enable reducing complexity and simplifying some of what we do. So this is the same patient journey. So the symptoms identified. So by the time you get to diagnosis, you've probably gone through a minimum of 10 systems, from the GP system into the hospital system, the PAS system, the labs, the RADs, before you're diagnosed. And again, that data is looking differently. And unless the IHI is embedded, it's currently impossible to join that data to the patient, or for that data to follow the patient. And again, the whole integrated, we've got an integrated care agenda, and that information is really, really important. Integrated care requires integrated information. And again, the IHI and standardization are really essential for both of those to work. I'm not going to talk about this. Lisa's given us a really good overview of that. And just in terms of interoperability, and I know everyone hears that word, and just there's the layers of interoperability in terms of legal, organizational, semantic, and technical. Standardization of our data and our documentation is an absolute basic requirement for interoperability. So just another piece in terms of where we are now. I'm not going to go into this in too much detail. We did actually conduct a data maturity assessment across the organisation. So we went into every facet of the organisation in terms of looking at our data maturity. And that really is so we can plan a stream of work based on the feedback. So that was done using an internationally recognised model called the DCAM, and it's got 4 key areas: foundational, execution, collaboration, and application. So basically that's scored on a 1 to 6, with 6 being enhanced and 1 being not initiated. We put in another score of 0 for not aware. So the results of our score was 1.6, 1.6 out of 6. So we have a very low data maturity score at the moment. The main outcomes for that were that most services have no data management initiatives in place or are in the very early conceptual stages. There are some services that are in that developmental stage, or there are pockets of good practice, but most of the survey comments indicate critical data management gaps, and we know that, and we now have identified all of the areas that we need to progress to fill those gaps. So what's coming next? So again, we have been working very closely with the Department of Health and HICWA around strengthening standard settings and implementation to co-design the national standard setting function, governance structures, stakeholder engagement, and standards development process and prioritisation. So that work is commencing over the next month. The Department of Health are going to establish kind of an interim governance for getting that work. HICWA have hired their teams. That work is going to start, like I said, in the coming months, certainly this quarter. Clinical data and clinical document standardisation. We have been doing quite a lot of work looking at the discussion paper, bringing to our executive management team to outline the rationale and a proposed approach for clinical document and data standardisation within the Irish healthcare service. So that was brought to our executive management team in the HSE, and there is a recognition that we do need to start this work. So we're currently actually pulling a piece together in terms of the resourcing and the programme of work and what that needs to look like. But again, all of these are intertwined. We can't do one without the other. So just on second last slide, Brid. The impact of not standardising our data. If we don't do it now, we have an opportunity now before we really start to digitalise. It'll significantly impact successful implementation of our national health policies, namely Sláinte Care and the health regions. Integrated care is at the core of our health system, and integrated care requires integrated information. Patient safety is a huge consideration. Clinical documentation and the data it is based on are foundational for successful clinical interactions and outcomes. Overwhelm, we have too much data currently in our system in too many different places. So for some healthcare professionals, they don't even know there's a data set relating to that patient. If you have an application and it's stored in the cloud and you're in a different healthcare setting, the healthcare professional has no way of knowing where that data is. And we know that we have some patients with the data. There's one patient that we looked at 3 weeks ago that had data in 4 different clouds, in some data in an EHR and then some in filing cabinets. It's also different ways of representing what we do. So even on a professional basis, it's probably easier for pharmacists, but certainly for nurses or for doctors, it's really challenging for us to actually report back on what we do, because we really have different ways of representing what we do. Documentation burden, again, that's a significant challenge. Decreased efficiency and accuracy. If we don't have good data, we can't have good reporting. We can't have analytical and visualization capability, and particularly as we head towards that kind of population-based method of providing care. Again, poor research capability, quality measurement, and performance benchmarking. Without good data, without good primary data, it's really challenging to have good secondary data or data for research. And again, huge interoperability challenges. So just 2 key messages before I finish. One is, look, digital health leadership, it is everyone's business. It really is. And this is, like I said, everyone's journey. And particularly for leaders who wish to thrive need to upgrade their skills and become digital literate, or they'll get left behind. And I guess that's one of the biggest challenges in the health services, because we're not digital first, and because we're not informed in terms of digital and the foundational pieces that we need to have in place to enable good digital health. That's a challenging space for us at the moment. So I would urge you, anyone with a voice, use that voice. And like I said, advocate for good digital health and for data standardization. And again, I particularly like this quote: one of the ways that getting a better understanding of digital informs better decision making is that leaders gain a better appreciation, not only about the many benefits digital offers, but also about its limitations and deficits. And there are limitations and deficits in terms of digital health and the ways in which humans should best interact with it. So I'll leave you with one message, which is data right at capture. And I think as healthcare professionals, that really is a core takeaway message. We need to be getting the data right going in. That is really, really important, because otherwise you're into a cycle of trying to clean it up, trying to attach to patients, trying to figure out, try to join up the data, look at any level of reporting and analytics. Getting the data right at capture is key. And thank you very much. That's me. And I'll finish ranting now. I hope there's no one asleep on the call.
That's great, Loretto, keeping up with you.
Thank you so much, Loretto and Lisa. They were both two fabulous presentations. It just strikes me that there's just an absolute mountain to climb behind the scenes. It's incredible at that granular level how much needs to happen, but that it really can help to streamline things and improve patient care at the end of it all. Is there any questions that anyone would like to pop into the chat for any of our four guests this evening? While anyone's
while you're waiting for those to come in, I think it's also quite an exciting time, I think, for people to realise maybe the work that's going on in the HSE, a lot of the building works and teams forming on it and starting to work together, quite effectively through the areas. And I think Loretto and Lisa, I think, have highlighted that really well tonight, and getting involved, with e-prescribing and the different projects to see. It might seem like we're trying to climb a mountain, but I think realising that we all have a part to play. The impact, if we want that interoperability around systems, is if we get information right, we can't stand over it, and realise that it will inform healthcare in different places as well. So that is, I think it's really critical, and I think it's an exciting time. It can be overwhelming, but it is also a very exciting time for the health service.
Absolutely, Brid. Yeah, the potential is just massive. So Nicola has come in there. Will the GP out of hours systems be included? They use Adastra.
I'll take from the National e-prescribing project part. We are looking to connect to them, so then I might leave Loretto and Lisa look to those as well from their project.
Absolutely, yes, because this will end up in the policy space. It's already in the policy space. So once it's in that space, it's for all of our partners, of which general practice are part of that. So yes is the answer.
Yeah. Yes, for the IHI too. So while the IHI is integrated into the GP practice management systems through the Clan Williams systems and the Health One systems, the out of hours systems are on our development pathway as well, to give that full GP landscape in terms of IHI coverage.
And Brid, so we will have minimum data sets. We will, we're starting to look at those now. So that'll be for every system, every healthcare provider in the country.
And from Brian there, can we write reports including the IHI from IPMS now to facilitate records linkage across data sets?
So Brian, is that in terms of connectivity to IPMS there, or? Sorry, just flashed up for a minute there, Michelle.
No problem. Yeah.
Where can I find it?
Writing reports, including.
Yeah, it's to pull out the IHI as an identifier associated with MNCMS identifiers, so that we can link to external data sets that have the IHI as well.
Yeah, that's absolutely the roadmap and the usage of the IHI. At the moment, our integration into the IPMS systems, Brian, it's a technical interoperability at the moment. So front-end users in the hospitals don't actually see the IHI at the moment. So we are moving to V8 of the IPMS system that's going live now in Q3 of this year. And we'll be using that as an opportunity to switch on display of the IHI in hospital systems. So there's very much an accelerated program in that space. We have a lot of work to do in terms of front of house education training and education around IHI usage. But this is where it gets to the really exciting space of to use the IHI to join up those healthcare systems and to bridge that gap and to make those connections.
And Brian, just to say the PAS as well, we're going to start doing a big piece of work nationally on the patient administration systems. Like Lisa said, looking at version 8, but we know there's some systems that are on a few versions behind that.
Yeah.
And that's one of our core systems. We're actually going to start baselining where we're at with PAS systems, hopefully in the next number of weeks, and just to see what the data is looking like. What level, because we know there's a number of instances. So there's a lot of work going to start in that space, because for digital health to be successful, we really need that spine, particularly as we digitalize further. We need the spine for all of our details, whether that's in a PAS or it sits above it. That's all we're going to have to look at that.
Mm-hmm.
Thanks, Loretto. So Roisin's just asked about the target date 2030. Sorry, apologies.
I think the target date is supposed to address this. I think the target date for the EU is that those I suppose that's not a target we were. I suppose from e-prescribing, we would hope to be live in areas well before that, but it will be a phased implementation. I don't think we can go live overnight with every community pharmacy and every GP with e-prescribing. If you even look at countries like Estonia, they had to halt their system where they tried to go to live too quickly, and their servers nearly couldn't handle the volume of information. So there will be a phased implementation for e-prescribing, and certainly it is achievable, I would think, in community areas, but for hospitals there is a bit of a rollout of that technology for hospitals to be able to submit e-prescription. Could be challenging potentially by 2030 to think of the amount of hospitals that would need to have an EHR and e-prescribing implemented it for us to meet that for every location by 2030.
Great.
I think to add to that with every e-health project that's coming on board now, the IHI is a core component of each digital solution. Yep. So that each new solution will have the ability of this interoperability and sharing information. So on the project that I work on, which is HIMS, which is the new software system for dispensing within hospitals, that will have the IHI in each individual patient record that's created. And that will allow the information to be collated in places like the shared care record, the patient app going forward, because you will have that single unique identifier that will act as the main linking point between the data across various different systems.
And I would also add in there the PPSN. That's because that's called out in the new legislation. That's something that we should all be collecting. That's one data field. And so obviously the others that Lisa called out, but that PPSN as well, really critical.
Yeah, I would echo that on the PPSN. Well, it's called out in the new, specifically called out in the Health Information Bill. When it becomes enacted, the PPSN will be collectible right across the board. We're also looking at an initiative at the moment using the Social Welfare Consolidation Act to enable the lawful basis for that widespread usage of the PPSN. And we've had favourable response from the Data Protection Commissioner on that. Because we need, I suppose, while the Health Information Act is coming, it's not here yet. So that's something that's in motion within the HSE as well. I suppose COVAX really showed us the power of the PPSN, and it showed us as well how culturally we've moved on as a country as well, and we're using the PPSN in so many of our societal engagements as well, that people are much more comfortable with that as well. So I would echo that with Loretto, that we should all be collecting the PPSN on all fronts.
And it'll also help us join up health and social care as well, because we know we have cohorts. We saw it particularly with Ukrainians coming into the country, and with others, say like in addiction services. It's really, really helpful to join up to the other components of service, like, social welfare, etc.
I see Helen has just put in a question, and I think I can answer that one, Helen. So I suppose it will vary from system to system. So where you don't have a patient administration system and there isn't an IHI seeded into it, how will that work with all these digital solutions? So for example, in the project that I'm working on, the HID service have the ability for multiple different software systems to utilize an API, which is like an interface with their index, so that it can take the patient demographic details that have been entered in the software system that's being utilized in your particular service, reach out to the HIDS index, and then attempt to return an IHI dependent on the patient demographic details that's been entered. So you're not limited to having a patient administration system within your organization to be able to utilize the IHI. And I don't know, Lisa, if you want to add anything to the end of that.
Yeah, that's it, Elmarie. I mean, we would work with a lot of systems that are maybe, you know, they're not digitally ready for the IHI, but they want to be ready, or they're maybe going out to the market to procure a new system, and they want to understand how will their data perform against the IHI. So we would work with a lot of systems in that regard. So they would send us over, you know, bulk loads of patient data. We would take it in obviously very securely and very sensitively with the appropriate governance in place. And we would match that to the IHI index and return it to that consumer system. We would send them back the IHIs, and we typically do that with what we call a health check, and we provide back analysis and feedback as to how their data is performing in that space. Now, ideally, we prefer to work with APIs, which are automatic programming interfaces, which allow for that real-time interoperable engagement, because as soon as you send back a seed file with the IHIs, you know, it's very static, you know, and if any of those data points update, you know, we don't benefit from that real-time lookup, but it is absolutely possible for sure.
Great, thank you very much, Lisa. Are there any other questions? Conscious of the time, I think we're just a few minutes past 9. If not, listen, thank you so much to Lisa, Loretto, Elmarie and Brid. It's a really, really exciting time, and it's great to get those insights at this stage. And as you say, collecting it right at point of entry is the way to go forward, I think. So thank you to you all for your attendance this evening. I think, as always, there's the opportunity to give your feedback. There'll be a link put into the survey, put into the chat box there now, and also an opportunity to complete maybe a CPD cycle on this and the upskilling in our digital literacy. What impact has this had on your practice this evening? So our next webinar is on Wednesday, the 22nd of May at 8 p.m. That's with Professor Stephen Bazier on deprescribing antidepressants. Don't believe everything you read in the papers. So we'll be looking forward to that. The invitations will be sent via email, and remember to keep an eye out on social media for updates. So that's all from us for this evening. Thank you very much for attendance, and thanks once again to all the speakers.
Thanks, Michelle.
Thanks,
Brilliant.
Bye.
Thank you.
everybody. Have a good
Bye.
evening.